This is a presentation about the new guideline for CTG interpretation. NICE guidelines for intrapartum care were updated in February 2017, and the main changes from the update were around how we interpret and categorise CTGs. Although the new NICE guidelines concentrates really on interpreting CTGs in labour, I just want to spend a couple of slides talking about interpretation of antenatal CTGs. So these are CTGs of women that are not in labour and not really having any contractions. So when we're interpreting these CTGs, we need to assess them really after a maximum of about 40 minutes or so, but obviously if there were really concerning features on them, then you probably get them assessed by a doctor before then. And we look at 4 parameters: baseline rate, variability, presence of accelerations, and presence or absence of decelerations. Once you've assessed the 4 features that you will say are either normal, non-reassuring or abnormal, you need to categorise your CTG. So when you're doing this, you'll look at your overall interpretation, and it will be normal if you've got 4 normal features, but it will be abnormal and probably need review if you've got 1 or more abnormal or any non-reassuring features as well. So this is a copy of the latest and updated CTG stickers that we're going to be using. This is the one for antenatal, so no uterine activity. And in principle, when you are interpreting and deciding on your 4 features and trying to put which category they fit into, the principles are the same as if you're doing one for somebody in labour. However, if you've not got any accelerations on an antenatal CTG, then this is really an abnormal feature and you need to get it reviewed by a doctor. Similarly, any decelerations that you've got will also be an abnormal feature and will need review by medical staff. I'm going to go on now to talk a little bit about interpretation of CTGs for women who are in labour. And the main thing to remember when you are interpreting CTGs on women in labour is that it's just one part of the whole assessment that you're going to be doing of that woman and of a baby, and that you shouldn't really view it in isolation. So any decisions that you make about care of the woman have got to look at the whole package, and you've got to try and keep your focus on the woman and what's happening to her rather than just on the CTG tracing. So we need a documented systemic approach to interpretation of CTG so that everybody's on the same wavelength, really, like ourselves and medical staff are all following the same parameters. But when you're interpreting CTGs, always keep it in the back of your mind that not every single CTG that you have is going to fit neatly into these little boxes, and that you might not be able to interpret every CTG that you see. But if you're worried, then you must ask obstetricians to have a look and come to a consensus between you about what's happening to this baby. When you're doing the CTG interpretation, it's a 2-step interpretation, really. So the first thing that you need to do is look at your 4 parameters, which is your baseline heart rate, your variability, the presence or absence of any decelerations, and the presence or absence of any accelerations, and decide whether these features are reassuring, non-reassuring, or abnormal. I'm just going to talk a little bit about accelerations, which sometimes it can be a little bit confusing when you're looking at accelerations and how to classify them. But I think basically what you've got to remember is that if the baby's heart rate is accelerating, then the baby is responding to stimuli, and so that's a healthy sign. So what they're saying NICE is that the presence of accelerations, even if you've got a bit of a reduced baseline variability, it's it's a sign that the baby is able to respond to changes within its environment and to like hypoxic changes, and so it's doing okay. If you've not got any accelerations on a tracing but every other part of it is okay, it doesn't necessarily mean that baby's becoming acidotic. So your baseline heart rate then, these are your categorizations. So reassuring features are if your baseline is between 110 and 160 beats per minute. It's classed as non-reassuring if your baseline is between 100 and 109 beats per minute, or 161 and 180 beats per minute. And an abnormal baseline is one that is less than 100 or more than 180 beats per minute. Right, so we're going to look at baseline variability now. Baseline variability is an indication that the baby is okay and compensating for any changes that occur that affect its kind of oxygen supplies. So a reassuring baseline is one that is between 5 and 25 beats per minute. A non-reassuring baseline is a baseline where it is reduced to less than 5 beats per minute for a period between 30 and 50 minutes. And an abnormal baseline is one that is reduced to less than 5 beats per minute for more than 50 minutes, or if you've got a baseline that is greater than 25 beats per minute for more than 25 minutes. These are indications that baby is losing its ability to compensate for changes in its oxygen levels. Right, so if we're looking at decelerations then, if you've got decelerations on your tracing, you need to be able to describe what they're like and where they are occurring in relation to your contractions. So we describe them as either being early, late or variable. And when we're looking at decelerations and you're interpreting your CTG, the longer and later the decelerations are, the higher the risk there is of acidosis, especially if you've got other changes on your CTG, such as your baby's heart rate's increased or you've got reduced variability. So deciding what kind of decelerations you've got is not always easy. I'm going to go through it now. But there is a flowchart on the stickers and there's a flowchart in the guideline which will help you a little bit, because it all sounds a bit confusing to start off with. But if you look at it logically, it makes sense. So when you're looking at decelerations, reassuring features are that you've got no decelerations at all, or you've got early decelerations, or you've got variable decelerations that have got no concerning characteristics that have been there for less than 90 minutes. And in a slide further on, I will describe what are concerning characteristics of a deceleration. Right, I'm going to try and describe non-reassuring features of decelerations now. And this is where it can get a little bit complicated. But I will try and talk you through it. So if we're looking at variable decelerations that have got no concerning characteristics, that is a normal feature if it happens for up to 90 minutes. Once you get past 90 minutes, it then becomes a non-reassuring feature. If you've got variable decelerations though that have got concerning characteristics in up to 50% of contractions, if that's been going on for more than 30 minutes, then you class that then as being non-reassuring. If you've got variable decelerations and any other concerning characteristics but they're occurring in over 50% of your contractions, then they become non-reassuring if it's occurring less than 30 minutes. And if you've got late decelerations with over 50% of contractions for less than 30 minutes, then that's classed as non-reassuring, but you can't have any other maternal or fetal risk factors, otherwise then it affects how you categorise your CTG, categorise this your late decelerations. So if we're looking at abnormal features of decelerations, your decelerations will be classed as abnormal if you've got variable decelerations and any other concerning characteristics that occur in over 50% of your contractions for 30 minutes or more. But if you've got any maternal or fetal clinical risk factors that you're worried about, then you can class these features as being abnormal if in a period less than 30 minutes. Late decelerations for 30 minutes or more are classed as abnormal, but you could reduce that timescale again if you've got any maternal or clinical risk factors for hypoxia. And an acute bradycardia or a single prolonged deceleration lasting 3 minutes or more is also classed as an abnormal feature. Right, so these are your concerning characteristics of any decelerations. So if you've got a deceleration that is lasting more than 60 seconds, so that means it's a little bit prolonged. If you've got a deceleration that doesn't return back to the baseline that it was prior to the deceleration, or if you've got a deceleration that's biphasic, so that means that it started to recover and then dipped again a little bit, so it looks like a W shape on your tracing. If you've not got any shouldering on your deceleration, or if you've got reduced variability within your deceleration, these are concerning characteristics because these are indications that your baby is not being able to react as it should do to the hypoxic changes that it's experiencing, whether that's from cord compression or whether it's because your placental bed's being squashed during a contraction. Once you've looked at your 4 features on your CTG and you've decided whether they are reassuring, non-reassuring or abnormal, you then need to look at your CTG and categorise it as a whole. So you would describe your CTG as normal if all your 4 features, when you've looked at them, fall into the reassuring category. You would categorise your CTG as suspicious if you've got 1 non-reassuring feature. I've done that. When you're categorising your CTG, you would say that it was suspicious if you had got 1 non-reassuring feature and 2 reassuring features on your tracing. But these features that you're looking at are your baseline rate, your variability, and the presence or absence of decelerations. And you'll just have to excuse the non-deliberate mistake on the slide because I've put 2 non-reassuring and it should say reassuring. So you will categorise your CTG as pathological if you'd got 1 abnormal feature or 2 non-reassuring features. And again, you're looking at your baseline rate, your variability, and any decelerations that there might be. And this is a copy of the latest version of the CTG sticker that you will be using and putting in the records. So as I've said earlier, this information is based on nice clinical guidance for intrapartum care, and it's reflected in our guideline for fetal auscultation, which is available on the intranet, and it's got more comprehensive guidance for you, give you a bit more information if you need it. I hope this has been okay for you. If you do have any questions or you're worried about anything or you've got any queries, please don't hesitate to contact me. You can email me or you can phone me on extension 2194 or come up and see me when I'm in my office, and I usually work about 7:30 till about 3:30ish Monday to Friday.